and then completed his family medicine residency at the University of California in San Diego in 1990. He has board certifications in family medicine and in hospice and palliative medicine, and is certified as a nursing home and hospice medical director, in addition to having certification as a healthcare ethics consultant. This next sentence is going to be an understatement. Dr. Steinberg has been a leader in multiple national and statewide professional organizations in post-acute and long-term care, hospice and palliative medicine, and advanced care planning. But Steinberg is perhaps best known for a rather unique way of practicing medicine. He takes his poodles on patient care rounds with him on a regular basis. Karl, let's hear from you.
Thanks, Stan. Yeah, I'm racking up the karma points by taking the dogs to work. If you've ever taken a dog to a nursing home, you know it's gets you right there. Stan, you want me to introduce you now or before you do your slides?
Oh, let's get it over with now.
All right. Well, let me. I might have to come out of this then. Let's see.
Oh, you can do it later.
Here we go. Okay. So Stan Terman, my good friend, graduated with honors from Brown University and then went to MIT, where he got his PhD in biophysics. Yes, biophysics. And after teaching molecular biology at the University of Iowa for 5 years, Stan realized his physician father was right after all. So he went back to medical school that included Johns Hopkins, University of Iowa, and the Eli Lilly Laboratory for Experimental Research as a clinical pharmacology fellow to fill out 4 years. Stan is engaged in several subspecialties in psychiatry, including couples and family therapy and forensic psychiatry, since he began practicing 50 years ago. I know he doesn't look it. But for the last 25 years, Stan has focused on advanced care planning to reduce the suffering of patients and their families who are faced with the huge challenges presented by advanced dementia and other difficult terminal illnesses. Stan lives with a view of the San Francisco Bay and some of its famous islands in Sausalito, California. And I've seen that view, and it is really spectacular. And he still misses his dog, Bruno. So that's that. Now let's see if I can get back to my slides. Let's see. What are you guys seeing right now? You see my slides?
Yes.
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 All right. Let me.
I
Here we
see the
go.
slides also.
Well, we see
Okay.
the slides inside of your,
There it is.
oh, there it is.
That's what you need.
Just the
All right.
slide.
Here we go. So, and I am going to kind of burn through these. I think what you really want to hear is specific to dementia, but just uh, because I don't know where everybody is from and what their backgrounds are. Euthanasia obviously is where a clinician administers a lethal dose of medication, right? They have that in Canada now. There's a lot of I guess, concern about the sort of slippery slope because more and more people are availing themselves of that. And they do have regular medical aid in dying in Canada, but very few people avail themselves of it because, given the choice of slogging down this stuff that tastes like shit versus having somebody put an IV in you and just do the job, it's no wonder that 99+% of people elect to have the doctor do it. Anyway, so medical aid in dying or MAID, this is a legally defined process where a physician and in some states a nurse practitioner or PA can prescribe a lethal dose of medications to a patient who has a terminal illness, who has decisional capacity, and has to be able to self-administer, to ingest. So that's basically what it is. And that's pretty much across all of the places in the US where it's legal, including Colorado. Um, some of the words that are used, and I just want to very briefly talk about it. Physician-assisted suicide, kind of the old terminology, but it's still, the AMA has debated this on a number of occasions, and they've stuck with that terminology, even though, you know, in all of the jurisdictions, if you avail yourselves of medical aid in dying, your death certificate, the manner of death is not suicide, it's natural. Um, which is a little bit, I guess it is a little bit untruthful if you go by the real, strict definition. Some of the other terms, physician-assisted death, um, aid in dying, voluntary assisted dying is what they say, like down in Australia, self-directed death, self-deliverance, death with dignity. So, in the same way that physician-assisted suicide kind of has a really negative connotation, it's sort of value laden. I think death with dignity kind of goes in the other direction, right? Because like Oregon, which was the first state, it's the death with dignity. Are you implying that if you decide to just let your pancreatic cancer run its course and die of cancer, you are not dying with dignity? There's something, that I don't like that. So anyway, I think medical aid in dying is a nice, fairly neutral term uh, for this. Um, just a very quick review since bioethics is important and I think plays heavily into all of these things we're talking about. Autonomy and just I don't want to make a value judgment about the people who are attending this seminar, but you look like you're mostly baby boomers to me. No, hopefully that's not offensive in any way. And we baby boomers, again, not to generalize, but autonomy is really important to us. We like to drive our own ship. We like to be the master of our own destiny and that sort of thing. And I think that's probably the thing that plays most heavily in these types of decisions. Beneficence means doing good, and as a physician, I want to do right by my patient. I want to help my patient, and if you can certainly argue that by prescribing a medication that will end their lives, if they are suffering, then you are doing good. On the other hand, it's very simple. People who are very literal, you look at non-maleficence, right? First, do no harm. How could you possibly say that taking somebody's life or giving them something that will allow them to take their life easily, that isn't harmful? Especially, if you go by life is precious and the sanctity of life and that sort of thing. And then finally, justice, and that's both large scale sort of social justice, but also what's fair to individual patients and so on. Some of the reasons people oppose this, people will say, if you're getting good palliative care, you shouldn't need to take your own life with lethal medications. To which I would say, that's one person's choice, right? That's one person's opinion. Uh, but trust me, I've seen plenty of people who get good palliative care who still have miserable deaths. So um, I don't agree with that. Obviously, the lethal prescription can be interpreted as being harmful. The sanctity of life I just mentioned, and then a lot of doctors, and the AMA still opposes it, right? Just kind of categorically, that it's not part of our job description as doctors to help people end their lives, and that undermines the doctor-patient relationship. It's explicitly in the Hippocratic Oath that you're not to give somebody something that'll take their lives. Inconsistent with our role as a healer, it could be abused, and all of the states have a deal where you have to make sure that the patient isn't doing it sort of because of undue influence, somebody in their family's twisting their arm so that they get a bigger inheritance or what have you. Um, but you don't ever really know that, right? You don't know. If somebody were getting that kind of pressure, would they even tell you, right? Um, and so a lot of medical societies still oppose. Very few are in favor, and most or a lot now are sort of neutral. So supporting it, I mean, it's an act of compassion, right? Our job is to walk the path with our patients. As a palliative care doctor, longtime hospice doctor, yeah, that's my job. And if my patient wants to end their life, it's their life, right? Certainly, alleviation of suffering. Um, and people have said, in the old days, they would just give a high dose of morphine, or, maybe somebody would say, "Hey, doc, how many of these would I need to take to make sure I do the job," or that kind of thing. Um, and I don't, I suppose it's better to have a legal pathway for it than to sort of do it in the shadows like that. These are the jurisdictions where it's legal. in order of passing the laws, and I won't go through it. New York just recently, it sat on the governor's desk for quite a while, but anyway, they're making some last minute amendments to it, but it's going to go through. So that's quite a few. That's a pretty big chunk of the U.S. population. I'm thinking maybe like 30%, and possibly Thad Pope or somebody else on the call would know, but it's quite a few people. And there are some states that have passed constitutional amendments that basically prohibit it. I think West Virginia was the most recent one to do that, which is not to say they couldn't pass a new constitutional amendment at some point if they ever evolve or whatever to allow it. For Colorado, I suspect if most of you are in Colorado, you're aware of these prerequisites. They're similar to most of the other states. You got to be 18 or up. You have to have intact decisional capacity. In other words, I mean, you could even have mild dementia, but you have to still be able to understand and to articulate your reasons for doing what you're going to do. You cannot be under undue influence. There's witnessing requirements for the request. You have to be terminally ill, which means 6 months or less. So the same criteria as hospice admission. Two physicians have to agree. You have to be a Colorado resident. That there are a couple states now where it's you don't have to be a resident. And I understand that the residency requirement, there's a lawsuit now pending in Colorado that challenges that. You have to be able to self-administer or ingest, and that can mean a variety of different things, but you have to be able to take it through your GI tract is what that means, whether it's oral, G-tube, anal, just as long as it gets into your somewhere in that tube. And there has to be a 7-day waiting period unless it looks like the person would die sooner without it. Most common reasons why people request it: losing independence, having to rely on others to do things for them, like just basic hygiene, fear of unrelieved pain or other physical symptoms. And in my practice, if people are on service with the hospice that I work with, Hospice by the Sea, and they request this, I will serve as a prescribing physician. And I have to say, it makes me uncomfortable when somebody tells me I don't want to spend up my kid's inheritance. That's my personal hangup. I mean, they're allowed to have any reason they want for it. It's their decision, and but I have to, I'd much rather hear, oh, I'm really worried that my pain won't be controlled. That's why I want it. And yeah, a desire to avoid leaving tarnished memories. And Stan will be talking a lot more about this kind of thing later, that can cause suffering. Wanting to stay out of the hospital, desire to be in control, right? Autonomy. And then a fear of losing decision-making capacity before you get a chance to do it. And most people have multiple reasons for requesting the prescription. If you don't want to participate in it as a patient, obviously you don't have to. You don't have to ask for it. Nobody's going to push it down your throat. As a physician, no physician is obligated to participate in it. But if a patient asks you for it and you're not comfortable with it, it's generally considered, it would be inappropriate to not refer them to somebody. And it is not permissible to basically refuse to transfer their medical records to a provider who would. There's lots of safeguards. People can change their mind at any time. They can rescind the request. Coercion is a felony. And there's no evidence so far in our country that access to medical aid in dying adversely impacts vulnerable populations. In fact, it's mostly, well-educated, wealthy white folks who avail themselves of this. And a great majority of people are on hospice when they do it. And again, the death certificate will reflect the cause of death, not to be overdose of medication, but whatever their terminal condition was, their nominal terminal condition, and the manner of death is natural. And just on this vulnerable populations thing, the disability community is very opposed to this. But most people in the disability community wouldn't be eligible for it anyway because they don't have a 6-month life expectancy. But I think their point is that it sort of devalues people with dementia or people with any kind of conditions medical conditions that impact their their sort of independence and autonomy and that. So this is what we actually use, and there's no set cocktail. This is just this is what the American Academy of uh, aid in dying medicine. This is what they recommend, and it has evolved over the years. It used to be Seconal or Secobarbital. Most of you guys on the call are probably old enough to remember Red Devils. I mean, I could buy them for 50 cents in junior high, and you know, you don't drink them with alcohol because it'll kill you. Barbiturates. But anyhow, so we give something if they're going to take it by mouth. We give some Reglan and Zofran so that they don't vomit it or less likely to vomit it. Um, Now, some people choose to do it rectally, people who are really prone to vomiting or have esophageal issues and whatnot. Um, and the rectal route, it takes longer, but it's effective, and it doesn't burn going down in the way that the amitriptyline does. Anyway, these are huge doses. Just for a little context, a normal dose of diazepam is 2 to 5 milligrams, let's say. This is 1,000 milligrams. A normal dose of morphine might be, 5, 10 milligrams. This is 15,000 milligrams. So it's literally enough to kill a horse. And so even if you only get a fraction of it, it's probably going to do the trick. It costs about $700, at least in my area. And like I said, you don't have to use every single thing on here. You can use different things. And now I just want to briefly mention what Stan will be talking a lot more about. But this is what we did. I'm sure what you did in Colorado, what we did in California, and what they still do in states that don't have medical aid in dying. If somebody wants to end their lives because they don't want to go from point A to point B in their terminal illness, they can stop eating and drinking. And this is always an alternative. It's pretty much legal in every state. And it's just what it sounds like. You stop everything, right? You don't give any food or fluids. And if you do it that way, you will probably be permanently asleep within 5 to 7 days. You'll go into a coma, and eventually your blood pressure will drop, and you will no longer be able to, perfuse your vital organs. Your heart will stop. That can be, 14 days can be a long time. My mom died with this, and it took her 17 days to die. And it was kind of excruciating. I mean, it was beautiful, but also it was just, we couldn't understand why her heart was still beating. It can be hard especially she was in a nursing home, but if you're doing this at home, that can be really difficult. And VSED by advance directive, or stopping eating and drinking by advance directive. That's what the bulk of this talk will be about. And for people with dementia, and also we have Dr. Thad Pope on our call today, and he'll be giving a talk that I believe it says 12 different ways to ensure that you. I don't remember the exact details, and Thad, maybe you can put it in the chat box, but that's coming up here in a few weeks through the San Diego Hemlock Society, and I would really encourage people to go to that. But basically, it directs people to, you could formulate an advance directive ahead of time that directs your caregivers to stop feeding you when you get to a certain point if you can't feed yourself. And these are some resources. There's a Hemlock Society at the bottom. I've got Stan's website. The Compassionate Choices, if you're interested in medical aid in dying, that's a good sort of for the politics of it and that. If you're interested in more of the nuts and bolts, the clinical stuff, the Academy of Aid in Dying Medicine, excellent resource. And if you're in a nursing home, and also hospice, they get federal funding, and you'll see this Assisted Suicide Funding Restriction Act of 1997. That makes nursing homes and hospices very leery of participating in this because you cannot use federal funds to do that. So I think I'm going to stop there. I do want to say, just so I don't forget to say it, that I do think, sometimes people in early dementia make a decision that they do not want to take a chance of getting into more advanced dementia. That to me, it makes me a little uncomfortable. I think, I take care of a lot of dementia patients. I'm a nursing home doctor, and for a lot of them, and again, I'm not living inside of them, but they look like they have a pretty good quality of life. They enjoy things. They still have meaningful interactions with their families. And I think it's kind of tragic to, cut off potentially years of that by making a decision to end your life just because you think you might have a bad spell of dementia, or you don't want to be embarrassed. So I just want to put that out there. Again, that's my personal opinion, and everyone is allowed to do whatever they want. But I think I will just leave it at that, um, and I'll go ahead and turn it over to Dr. Terman.
Just to comment on your last point, to which I agree, it's often called the 5 minutes to midnight goal, that you want to end your life just before you lose capacity or capability, could be physical as well as mental, uh, so that you can avoid advanced dementia. But there's another way to avoid advanced dementia, and that is to have a really workable strategic advanced care plan with a bunch of documents that are strategic and moral, and that's what we're going to talk about next. So,
Stan, hey, I see something in the chat box I wanted to quickly address. How painful is VSED for patients? And I've heard people say that it's terrible, it's awful, it's the worst thing in the world. And my experience, and I've taken care of lots of patients who do this, it's not bad even without meds. They're going to be thirsty. They're going to be, a little bit of a dry mouth for a few days. It is not bad. It's so much better than a lot of the alternative ways that I see people die. And Dr. Terman can tell you he did a fast for several days with nothing, and maybe you can share a little bit about that, Stan.
and it's on YouTube, and it's called Fasting, a peaceful legal way to hasten your dying. It was about 2007, and I went 5 days, and I was very, very comfortable. And my teenage son came in at the time with a pepperoni pizza, and it didn't bother me at all. So, but it is essential to treat thirst, and that particular video, and of course other materials, shows you how you can take care of thirst. Okay. So let me see if I can share my slides.
And while you're pulling those up, Stan, maybe, Stan and I took care of a patient many years ago at a very fine nursing facility in San Diego County who had probably colon cancer that she didn't want to work up for, and wanted to do a VSED, and she started on her fast, and she essentially the nursing staff would go in there and sabotage her attempts. They'd be like, "Wouldn't you like some ice cold lemonade?" And instead of dying in a couple of weeks, it took her about 42 days to die. I believe she developed some, pressure sores and as part of that. And it was complete sabotage. It was really, really destructive. And by the same token, I think, there's this notion of minimal comfort feeding, like giving people a little bit of food just to maybe make the caregivers feel better. I think it's a really bad idea in general. If you can go complete no food, no fluids, I strongly recommend that. And as far as the comfort level, people can go on hospice when they're doing it, and comfort meds, benzodiazepines like Ativan or Valium, and opioids like morphine or a fentanyl patch can be super helpful. So, okay, go Stan.
That's great. Well, thanks. I agree, and we'll talk some more about that later. So the title that I want to propose for this talk, also for an article I will be submitting very soon, can advanced care planning for late-stage dementia effectively reduce how long and how much you and your loved ones will suffer? To which the answer is yes, if your strategies are clinically appropriate, legal, ethical, and moral. The story of Sarah, to explain who Sarah is, it's in the handout. She's a fictional composite patient whose problems and treatment reflect real common challenges and ineffective treatment. So she was an example of the dangerous, dismissive, non sequitur fallacy. I'll explain what those words mean later. by casual observers who say she's not really suffering, she's just sitting there. Which means they extrapolated from her calm exterior, which was really withdrawn behavior, to wrongly assume that her mind was in a state of inner peace, when actually she had non-observable suffering, which I abbreviated NOS, like it's a signal, not like SOS, that we should be taking account of. So please read these pages before or after the presentation. And here we have Pan Haskins. Back in 2021, I interviewed her twice for 12 minutes and for over an hour. The purpose of the interview was for me to give her, as her devil's advocate, an opportunity to argue vehemently why she wanted to end her life by VSED. And she did a good job. She convinced me, and therefore she convinced others. It was part of an insurance policy so that no one could sabotage her. And if anyone tried to, you know what happens? They go into a judge who's naive, perhaps, to the idea of what VSED is all about. And they say, Judge, just give me a few days temporary injunction, please, so that we can arrange for more data to come by your way. And they abort what's a difficult process to begin even once, let alone twice. And so to prevent that from happening, she did the videos, and she also did a post, which I will talk about in a moment. So this is what happens. You say, go away. I don't want any food or any, so I think I'm on the wrong video here. So let me see. I'm so sorry.
It's okay. It looks like you were on the right on your slides.
Yes, it did look good. Oh, I know what to do. So take care of that. And file, reset. That should be the one. Okay, that's the right one. All right. Let me see if this is right. Oh, well. It does have the F there. Okay. So Pan received medical legal insurance to ensure she would have a timely and peaceful dying. She did not qualify for medical aid in dying. She wasn't terminally ill. And so she used VSED. And that was right for her. And I filled out, as I mentioned, a VSED post, which carried the authority of physician's orders and included her consent.
Dr. Terman, we're not seeing your slide.
All right. Thank you very much for letting me know that. So I have to go to share. And side by side. And you know what? Maybe I'll do a slideshow instead with the PowerPoint. Does anybody see his PowerPoint yet? No?
There's just a
PowerPoint's
smidge.
taking a while to populate, and we can see your face also. So the PowerPoint is really small on the screen.
All right, well, let's go back to the PDF, which was my other alternative. And
to do a screen share.
yeah, I had all this worked out before, right? As usual, right?
You did. Best laid plans.
Yeah. All right, we're going to have to start with another. There used to be something called the My Way cards that were really cards. And now
There we go.
they are all digital. You can see the My Way cards. And I want to open we're back to okay. Can we change? Okay, I guess we're back to this one.
Now you need a slideshow in your top top row menu.
Now I'm in a PDF, so that shouldn't require a slideshow. Yeah, okay. I'm so sorry for the technical problems. I had an old version that was up there, and there are two forms that I will refer to interchangeably. POST is the national term, and MOST is the medical orders scope of treatment in Colorado. And in caring advocates, we have the strategic advanced care planning as one option, where the posts are actually completed during advanced care planning, and they create what's called a future posts. And the reason we do that instead of waiting till the patient gets to be terminally ill is because by the time they're within a year of dying, they will be most likely not capable of making medical decisions anymore. And Shalowitz et al. Reported that for all diseases, 68% of the time they were right, meaning they were wrong the rest of the time. And it was even worse when you're talking about dementia, 58% concordance or agreement. So if you want to successfully control the last chapter of your life, you have to make these decisions yourself while you still can. And my recommendation is to do that during advanced care planning. Another story I want to tell you about is Margot Bentley. So we have Sarah, and then we had Pan Haskins, and you can see her videos. And then Margot Bentley was a well-informed, well-motivated patient who, when she was young as a nurse, was taking care of advanced care planning, advanced dementia patients. And she did her best effort to create a living will in the province of British Columbia before it even became law. And a living will said not be provided with nourishment or liquids, and to be allowed to die if I suffer from extreme disability with no expectation of recovery. Unfortunately, Margot omitted the word oral. The result was that she had to endure 4 years of court-ordered force feeding, while she could not absorb what the doctors ordered the caregivers to put in her mouth. And I'm going to show you two pictures, photographs. This is when she was a nurse. This is when she began spoon feeding. And you can see.
Stan, Dr. Terman, we're not seeing the advancement of the slides. We're still looking at my way cards. I'm sorry.
Wow, okay. That's a tragedy. Stop the share. Okay. How?
I think if you go back to that one and actually just do slideshow, it will work.
Yes, you're right. I will do that. see if that, do you have a picture of a nurse and a patient being spoon-fed now?
Yes, yes, we've got it.
Ah, thank you.
Yay.
Okay. All right, so if you want to close your eyes, the next is going to be a little bit difficult to view, but it's actually in my advanced care planning deck of cards, and that is Margot when she was just before she was about to die. And so I come down to a sentence that is, after almost what a difference one word, oral, could have made. And I consulted with her daughter extensively. And then I want to tell you about my patient AK, because there's been a lot of progress in advanced care planning for dementia recently. So she came to me in 2019, and we'll call her AK. And then when her suffering became intolerable, she came to me again through her husband when she was in an advanced stage of dementia in 2023. But she needed two actually different kinds of innovations, which I would happen to be working on at the same time. I was broadening the concept of suffering, which was eventually published by a prominent journal that the Alzheimer's Association runs, called Alzheimer's and Dementia. And then the second treatment of last resort I was developing was moderate anesthesia to make her unaware of her suffering if patients' suffering cannot be relieved by non-sedating treatments. But she could not use, here's the problem, VSED by AD, or what I call natural dying, because she retained the physical ability to eat and drink without assistance. She was living in what I call the dementia gap. This is her husband, Jay, who has graciously suspended his or forgiven his confidentiality. And we worked very hard to understand why he was so much profoundly grieving that what we did was we took the patient. She had already established a patient decision committee, which included her husband and her 3 children from both marriages. And it also included a caregiver that got to know her very well. And instead of her, because she was now without decisional capacity, she couldn't answer any questions at all right now. So we had the decision committee use their substituted judgment, which is their knowledge of her when she was had capacity to rate each one of the conditions as either for the intensity of suffering, and if they reached the level of intolerant, then she would get moderate anesthesia. The advantages of a patient decision committee is that no one has to shoulder all the existential angst from making an awesome decision. It's likely more accurate, although it hasn't been proven yet, when you have multiple decision makers chime in on multiple conditions and just ask one person about one condition. It may prevent self-interest behaviors of one agent that would be a conflict of interest if discovered. They may be able to discover social history and personal references to help withdrawn patients awaken to enjoy life. And it gives emotional support now, and reduces grief later. So we use the patient decision committee for both SACP at the top, strategic advanced care planning, and now care planning. Now care planning is an end-of-life protocol as opposed to an advanced protocol. To continue with some concepts that are relevant, the dementia fear causes many patients to experience anxiety and worry. They wonder, will others honor my wishes after I no longer can speak for myself? The question again, will my living will succeed in preventing prolonged dying with suffering in late-stage dementia or another terminal illness? As Karl mentioned, the dementia fear can lead to suicide attempts by hastening dying in a variety of ways. You could stop life-preserving medications like anticoagulants or heart medications. And if you do this, you prematurely sacrifice many months to years of reasonably good quality of living. Also, patients in middle dementia who might be having a good time, they get a little pneumonia, and instead of treating them, the caregivers say, give her no antibiotics, no hydration, and let it go. We want to use this as an opportunity. When in fact, they still could enjoy life. And then the worst of all is that when loving spouses, every once in a while there's an article about how someone's been married for 50, 60, 70 years, and their spouse kills them because they are having so much suffering in advanced dementia. None of that will be necessary with adequate advanced care planning. And I use the slogan, plan now, die later, to live longer. Planning principles can complete strategic advanced care planning by diligent, deliberative decision-making. They can determine what treatment they will or will not receive if they reach specific future conditions. If you have confidence that others will honor your end-of-life wishes, then you don't have to plan to hasten your dying in another way. The goal for living wills is that what you want is what you get. But without effective strategies that also need to be moral, and I'll explain why, you may not get what you want. And this is Nolo's living will that includes voluntarily stopping eating and drinking. There are too many words here, but it says Alzheimer's patients may want their healthcare agents to enforce. Good luck, agents cannot enforce, so you have to have hope. And hasten is immoral. I don't use that word anymore. And then it says many healthcare providers do not understand or accept that it can be natural and pain-free, and they may refuse the request. So what is their strategy that they suggest? To write clearly. That is not an effective strategy, in my opinion. And I've been at this for a quarter of a century. And if I don't recognize my family, I believe that that would be best for me to die, which is both wrong and immoral, because sometimes you can enjoy your family even if you can't recognize them. And it's immoral again when you're in institutions that have a faith-based, and people don't in some areas don't realize it, that there are only institutions that are, in fact, for one of the faiths, 1 out of 7 patients will be enrolled in their hospitals or their hospices or their skilled nursing facilities. And another point, you can give your healthcare agent the power to make sure, that is not, so it's a very misleading living will. Even if they did show you how to precisely be clear, which they do not. This is my favorite slide, and I'm going to come back to it later. One major challenge and source of conflict is paternalism, where authorities, they could be physicians, nursing home administrators, even judges, they may mean well, but they may have their own agendas or bias. And if they exert their authority to help you as they, not you, feel is right, some consequences are possible. They won't be respecting you as a person. They won't honor you, your living will. They will not uphold the bioethical principle of autonomy. They may increase your suffering. They may force you to do something that's non-beneficial, such as feeding, and waste your family's resources or the society's scarce medical resources unfairly. In other words, they violate the 4 principles of medical ethics. 1 out of 3 Americans will die with dementia, and the cumulative lifetime prevalence is 42%, and it's even higher for Black women. There are 4 challenges to attain a timely and peaceful transition. One is that you lose decisional capacity sometimes years before you die. And so just when you need it most, you can't speak for yourself. You can't say what treatments you want or don't want. You can't revise your living will so it becomes morally acceptable and therefore effective. And then there's sometimes there's for many patients in dementia, there is no plug to pull. You may not be dependent upon high-tech treatment to sustain your life that can be withdrawn or withheld to allow natural dying. And as of this moment, to my knowledge, almost all, if not all, dementia-specific living wills request the cessation of assisted oral feeding, and hydrating. And there is maybe a little photograph you'll remember. The clinical and moral arguments for natural dying is that for this unique stage of life, feeding is no longer loving and food is no longer love. In fact, a point will be reached as dementia progresses when oral feeding and hydrating become unnatural because patients would not be able to feed themselves, forced if the living will states that it's not wanted, and unethical. All dementia-specific living wills have flaws, and Karl and I published a paper in a prominent journal. And by the way, if you see a DOI in any of the references, if you cut and paste, just copy from 10 point to the end of the, in this case, 7, and then put it into your browser, you'll see the entire paper right there, open access. The Caring Advocates Natural Dying Living Will includes natural dying, which is different than many other VSED by AD, stopping eating and drinking by advance directive, because I insist that on a second unique order, which is always place food and fluid within the patient's reach, which upholds the highest legal, ethical, and moral standards and allows for this argument that the patient died from their underlying brain disease because they could not recognize food and fluid or direct their hands to put them in their mouth. Challenge 3. This is new to some people. It was new to me in 2023. The patient can eat and drink without assistance. This means that the patient will be living in a therapeutic desert, and patients without another treatment of last resort will have to wait months, even years, because it is not legal, ethical, or moral to withhold food and fluid. Others can view it appropriately as illegal euthanasia in the United States. And here are a couple of people who are eating with their hands, sometimes delicately, sometimes messy, but they get enough to survive. And here we have the dementia gap defined. It is the time between having sufficient capacity to voluntarily stop eating and drinking. On the left, that man can say, go away, I don't want any food, I don't want any water. And on the right, we have a lost capacity to understand what is food and fluid and how to direct the hands to put them in one's mouth. Ceasing assisted feeding cannot work for patients who are not dependent upon that assisted feeding. And I define these patients as living in the dementia gap. They need to sign a consent form for moderate anesthesia. And that means they have to accept the fact that consciousness, once it is lost, may never return before they die. And they also may die unintentionally sooner. So the alternate treatment of last resort moderate anesthesia are for patients who accept sedation to unconsciousness if they live in the dementia gap, have intolerable suffering that fails to give them relief with less sedating treatments, and they're willing to sign that consent form. And then there's another area in which I've done some innovation called non-observable suffering. I mentioned this briefly before. It means that the observable burden of suffering of disease above the water is dwarfed by the NOS below the water. well, in icebergs, it's about 90% below. It's reasonable to estimate 50% from many opinions I've collected, but I estimate that 500,000 Americans currently live in the dementia gap with intolerable suffering. The problem is physicians do not treat what they do not see. And I want you to read this after, but this is from the paper Karl and I published in the Alzheimer's and Dementia, and it indicates in 2024 where we were at that point in the progress, where there is some physical suffering that's hard to detect. You can't see inside the mind to know whether there are these emotional issues. Existential suffering is mainly related to being so isolated because you cannot relate to other people. You've lost, the relationships have died because you can't remember, you can't communicate, and your life has, number 4, disruption of your life narrative has rendered your life much less meaningful. And we're no longer just looking at you, but we're looking at the suffering of your loved ones in the 5th category, which you can read about later. And that's our paper in Alzheimer's Dementia. Why does morality matter? Because if your life ends, it's irreversible. All concerned want to make sure that it's the right act at the right time, and those in authority might insist that it be moral, otherwise they won't accept, for example, modern anesthesia or even natural dying. There is a workaround, the moral principle of double effect. It's okay to commit an act whose bad outcome was foreseen as possible if it wasn't intended, the bad outcome, and if the bad outcome was not the means to obtain the goal of, for example, reducing suffering. People will die, yes, but that's not your intent. It's never moral to kill someone in order to relieve their suffering. And I'm writing another paper on that. So I wrote a paper on the morality of natural dying, and now I'm writing another paper on this topic in the dementia gap. Another unique aspect of my protocol for advanced care planning is it doesn't ask the if-then question. If I reach this condition, then this is the treatment I want. Instead, it asks you to judge the condition in terms of how much suffering it would cause you and your loved ones, with there being 4 choices: mild, tolerable, severe, and intolerable, each of which moves ahead to a post. And there it is. Intolerable suffering gives you the moderate anesthesia post. Severe suffering, the protocol of caring advocates converts to a living will that says natural dying post. If your suffering is tolerable, then it's selective and limited treatment. And if it's mild, because of course you still have dementia or another terminal illness, then you can either choose one last attempt at CPR or just limit your treatment to things that are not in the ICU, not invasive, not burdensome. You don't want a feeding tube, you don't want ventilator assistance. Why is judging suffering preferred over deciding treatment? First of all, it's much less likely that future physicians can override patients' autonomy or not involve their issues. Second, the pulse is the most powerful end-of-life form available, and it's directly correlated. And it's easier for patients to respond. If their cognitive ability or healthcare literacy is borderline, they can still say how much suffering would be. They don't have to know all the nuances of different kinds of treatment. It may generate a more accurate reflection of their end-of-life wishes, and it may prevent deciding on a life-determining event just because you want to leave as well. But it's more, can be considered more authentic and more sincere. I've had patients who complete the My Way cards and they answer moderate anesthesia for everything, or natural dying before that became an option, for everything. And in fact, that cannot happen because it doesn't make any sense. For example, if someone needs help by two people to take a shower, or by one person to dress every article of clothing, that cannot be intolerable suffering. I really like Colorado's most, and you can come back and read this later. And there it is. And it's very patient friendly as an advocate. One of the reasons PULSE are so effective is because of that underlying sentence. First, follow these orders, then contact the physician, nurse practitioner, or physician assistant. And what are we talking about here is no delay between when you implement the PULSE. It is actionable right then and there in any setting, inpatient or out, home or not. And there's just no time for a conflict to arise when it is immediately actionable. And I add two strategies in addition. Only patients can change a pulse, so it is durable or even irrevocable. And I insist that the orders be consistent with the living will. And how do you switch from, how does all this happen? Well, someone completes advanced care planning, and then somebody who's concerned requests any member of the patient decision committee, I think Sally is looking like she may be ready to die, or much better stated, she might have a lot of suffering. Could you take a look? So the patient decision committee members compare the current condition of the patient with the qualifying conditions in the patient's living will. And if they believe that the patient has reached qualifying conditions, then the currently active proxy agent engages the treating provider in a post conversation that ends up with the physician saying, okay, I'll implement the post. And then that means that advanced care planning has been successful. Illustrations are very important. For a variety of reasons, this is one of two slides. They clarify and make it easier to understand the conditions. They add the relevant clinical detail, a picture's worth 1,000 words. They depict the patient's families and emotional responses. Sometimes they resonate deeply with the emotions of the planning principal, the person who's doing the planning, advanced care planning. And when we get around to translating to other languages, they will remain the constant. And I'm indebted to Coley Perry for making these illustrations. They also help with the idea of non-observable suffering because the facial expressions can reveal what people are feeling on the inside. And we can use word clouds and thought clouds to more specifically reveal the sources of NOS, non-observable suffering. So, AK. Here we have a family where the most common named syndrome, or in fact, in some living wills, it's the only one for advanced dementia. The patient cannot recognize his family. And that is just so, so tragic. But the point is that even though he doesn't know their names, doesn't know their genetic relationships, guess what? They can still have fun. And here we have a couple, I call this the dancing and singing non-recognition condition. just having this one where there's no recognition is not sufficient in any living will that I would want to complete myself, unless it's accompanied by, but if I can enjoy my family, then the deal's off. I don't want to die in 2 weeks. I don't want natural dying. I don't want moderate anesthesia. I want these nice people, whoever they are, to keep on coming back and enjoy our visits together. And even if I can't remember these visits, there's something to be treasured about living in the moment when they have so much fun. Some people cannot express or respond even yes or no. So here's the daughter saying, Mom, are you hungry for breakfast? It's 8 o'clock, you know, and all she can say is, ba, ba, ba. Incontinence and needing the other people to change you, which is dependency at its worst, can be extremely distressing for some people, and for others, it's not that bad. So I have a wide range of people who in terms of whether they consider it mild, tolerable, or severe. And then there is the elopement. Here's a woman who's very confused, not thinking correctly. She thinks she needs to desperately leave her home, opens the dining room window, and then is even more frightened and her life is in danger. And that can be these are some of the main things, reasons why people go to nursing homes. Elopement, incontinence, and fighting caregivers. Leave me alone, stop bothering me. And they're on the verge of calling for a third or fourth person to just simply weigh the patient who's just being uncooperative because she just doesn't understand. But what's going on inside? Look at her face. She's in anguish. She's frightened. And then we have something called the a condition which is called ambiguous loss, and it leads to ambiguous grieving. His daughter is saying, I can't finish grieving because he's still here. While her husband is saying, he's already been gone a long time. She is talking about how he looks physically. He is relating to his mind has been gone for a long time. And this is what the condition that AK had in 2023. There are two other conditions she did not have, but are common. We have patients who are saying over and over again things like, help me, help me, help me. And it just turns off the staff who derive their career satisfaction from helping patients get better. And there's nothing that can get this patient better. So we have one guy walking away, abandoning her. The nurse is looking back and she says, oh, she's always saying that. She's dismissive. And the other fellow is just angry because he can't do anything and he's distancing from her. What a reception. Isn't that awful? And now we have what started all off, my inquiry into non-observable suffering, is that a patient is agitated and a doctor doesn't know why. And the patient is thinking, but can't say the words. Why can't he see that I'm in pain? And he may be treating her with things to calm her agitation, like benzos, like antipsychotics, and she will calm down, but you may still be in pain. There are 4 strategic documents. We've only been talking about the natural dying living will. There's a bilateral durable power of attorney for healthcare decisions that forms the patient decision committee and also has a consent form and a contract so that if your future demented self says, feed me because he's forgotten about your goal, what your proxy agent says will legally prevail, especially because you waived your legal right to object to your proxy if you are demented, which is very important because many state laws say you don't have to have decisional capacity to receive a requested life-sustaining treatment. And the Natural Dying Agreement has a dozen other strategies. And then, of course, there are the future posts. I think is it time for me to stop and ask for questions, Susan?
Yes, Stan, thank you for noticing the time. We're just about up to where we want to do some questions and answers.
Okay.
So this slide looks important.
So let me just summarize. The dementia gap exists. So moderate anesthesia is necessary to relieve patients' suffering so that they're not in a therapeutic desert waiting perhaps months or more longer to lose their ability to self-feed and drink. Non-observable suffering exists. So we have to ask planning principals while they are engaged with the patient decision aid and see these graphics to say that one this is how I would feel. You may not know it then, but keep it in mind now. So the agent will inform the treating physician. She possibly is in pain. Why don't you treat her empirically? And some doctors will do this anyway, of course, with analgesics. The advanced care planning principles do not need to make decisions about medical treatments, but they do need to judge the intensity of suffering for each of 40 conditions, which is comprehensive. And the primary actionable end-of-life document is no longer the agent instructing the treating physician what to do based on the living will, but a future post that is the most effective document to use in advanced care in end-of-life. And so this is, if you get a chance to read the handout, this is my favorite slide because it goes from absolutely no advanced care planning to where we are at the moment, where you go from hope to confidence, and that your wishes will be fulfilled. Plan now, die later if you have capacity, and if you're concerned about a relative or close friend who's already reached advanced dementia, ask about now care planning. All truth passes through 3 stages. First, it is ridiculed. Second, it is violently opposed. And third, it's accepted as being self-evident. I'm still waiting for the third one, even a little less on the second. Thank you, Arthur Schopenhauer. And now I can stop the share.
Okay, thank you. Thank you for stumbling through the slide issue and all that, Dr. Terman. While we have you, as far as the chat goes, one of the most pertinent questions I think was someone had said that they went on the Caring Advocates website, your website, and sees that there are different natural dying living will plans. And is there something that you can say about different plans and how to differentiate and pick through them?
Okay. That website is an old website. I don't know how he got it. He emailed me earlier today. My Way cards are not for sale. They are for use by a professional in the end-of-life area. It could be an end-of-life doula, a bioethicist, a physician. And at best, what we do is we give you the set of 40 conditions. You decide how much suffering each one causes. Then we review it with you. and then we move on to the rest of the program as you wish. Some people just stop at the living will. Some people get all 4 documents. We are continually developing this program to scale it up and to reduce its costs so that it's available to more people. Okay, but the website is ancient, and I've been working more on the writing and the program development than on the website. That's next.
All right. Thank you. So you'll be sending your contact info out that people will be able to see your current website and all that.
Sure.
Great. Going back to Dr. Steinberg, there were a couple of questions about VSED. Wanting to know if it's painful and yeah, mainly what it's like to go through VSED. It's tolerable.
Yeah, and I've watched
that, but
yeah. I mean, if you've got a terminal condition and you've got the option to do medical aid in dying, I think most people would much prefer that. But let's say you have ALS and you don't have a 6 month or less life expectancy, then this is certainly something you can do. And Dr. Pope's on the call with us, and he's got this idea, or he and some of his colleagues, that a person who wants to do VSED can start there fast and then find a doctor to say, okay, they're a couple days in. If this runs its ordinary course, they're going to be long dead in 6 months. And then, of course, that might not help in Colorado with a 7-day waiting period. But then on the other hand, maybe it's imminent and it can be waived. Personally, I would be a little uncomfortable prescribing under those circumstances, but maybe Thad can mention a little bit about that. But what I would say is, I've never seen anybody suffer significantly from it. And usually the first few days, people are talking about a dry mouth, they're thirsty. Um, when you're lying in bed for a really long time, your back starts to hurt, that kind of stuff. Just, but nothing severe. And generally, when I have patients who do this, and I haven't had one in a while because we've got medical aid in dying now, but you prescribe comfort meds for them, and they can take, or their family can give them around the clock medication to keep them drowsy and out of pain. And so yeah, it's not at all a bad way to go. And we see people die of all kinds of other things that are very unpleasant, and I'd say it's a very peaceful death. Yeah.
And I think it's highly recommended that you have hospice on board, correct?
Yes.
So that they can they've got the medications and such that will help treat the symptoms. I worked with someone who wanted to do VSED. She didn't qualify for hospice though. And so she started VSED. And then because she was in process of dying from VSED, then hospice was willing to come on board. I mean, she interviewed ahead of time and was told, yes, when you're a couple of days in, call us back and then we'll come in and support the process. So
I see that Dr. Pope put something in the chat box, so that's interesting. I don't know if you want to actually speak that. That would be fine if you'd like to. You're probably the preeminent expert on this stuff.
Well, I don't want to take up your and Stan's time, but the idea of starting VSED to make yourself terminally ill, which would then qualify you for MAID, is possible, right? We have documented, a lot of cases from New Mexico and Oregon, but it's an extraordinary option, and many MAID physicians are reluctant to to do that. I mean, there's some Colorado physicians who got a lot of notoriety for qualifying patients with anorexia for MAID, which is similar, and that was very controversial. And so it's an option, but it's going to be very difficult to find both an attending and a consulting physician willing to certify you for that.
Thank you.
Yeah, thank you so much for all of your input on the chat. That is, it's been super helpful. Question about when you have dementia and you're still decisional, you've got a dementia diagnosis and you're still decisional, how do you decide when you might want to end your life. I've had a conversation with people around, would you rather die too early or too late? As in making a decision to end your life while you're still decisional capacity, you will definitely be leaving time on the table, good quality time on the table. But if you wait too
Yeah,
long,
I would say on this call, there's probably 147 different answers to that question,
right?
right? I mean, it's a very, very personal decision. And, some people have seen family members or others really suffer with advanced dementia. And, the nun who becomes this, yelling out horrible words that would make a truck driver blush and then think, I don't ever want to be that. I think about my grandmother who was kind of a bitter person, as a 70-year-old. But when she got dementia, she became this totally huggable. You'd take her a Cadbury Caramello bar and she'd be like, "Oh, this is delicious." And I'm thinking, it's the happiest I've seen you in 40 some years. And, I wouldn't want to take that away from her. So really, really very different. I don't think any of us likes the idea of losing our mental capacity and becoming dependent on others. But does that mean we'd rather be dead? And it's an individual call.
So the way I approach that question to answer it is when suffering becomes severe or intolerable. And how do you know whether the suffering is severe or intolerable? The planning principle judges each of 40 conditions. And then the patient decision during advanced care planning, okay, say in 2026. And then in 2046, they look again and they say, well, has this person reached any of those conditions, those qualifying conditions? And if they have, then that would be timely dying. So what the goal of timely dying is to live as long as you possibly can, as long as your suffering is mild or tolerable, and then to stop at that point.
Thank you. Here's a question that everyone will be interested in. As far as writing a directive that might say that if I'm in late stage dementia, I don't want hand feeding any longer, or from that point even instructing to withhold nutrition and hydration altogether. If you have this written down, what are the chances of it being able to be followed, especially if you are in a nursing home or assisted living home?
I'd say nursing home, very, very unlikely that would be followed. Assisted living, also probably, you might find a place that would be willing to do it. In a private home, sure, if you've got caregivers that are on board with it. And, it's an equity issue, right? Not everybody, most people in nursing homes are on Medicaid, they're indigent, and they don't have the money to go out and have this happen outside. But who knows? There may be we need some test cases, I guess, some precedent to see if we can move this along. Right, Stan?
Right, Carl. And I had a patient as an example who was in a memory care unit for almost 2 years near Los Angeles. And there was a big day when the furniture that they had moved to the nursing home, to the memory unit to make him comfortable, was moved back to his place of residence. As the prescriptions that the medications that I was prescribing were being filled at a pharmacy to be there ahead of time. And the patient, the doula and others were assembling, the family members, to assist. And so when he got home, they tried to make him comfortable and hoped that he would say, "Oh, I'm home again. This would be nice." It didn't happen. He became exceedingly agitated. They started with small doses of sedation, and then they eventually brought about unconsciousness, and he died several days later. So sometimes you have to come out of the institution back to home.
Mm-hmm. Okay.
But before we wrap up, I do want to say something. Stan's idea about future pulse, it also has not really been tested. And I'm the immediate past president of the National Pulse Collaborative, which is all the different states and their MOST and MOLST and TPOP and these portable medical order forms. And we National Pulse don't necessarily endorse this concept of a future pulse, and it's not clear that because you're going to ask a doctor to pre-sign something, right? I mean, you wouldn't probably pre-sign a prescription or a check, or I don't know. But it's an interesting concept, and certainly pulsed forms, they are actionable medical orders, and I think the idea behind it is a good one, but it hasn't been tested.
Except in the state of Michigan that I know of, posts never expire. And maybe we need a test case. Maybe Thad can suggest how we could arrange for that. But what I do on the post form is I not only have the patient's consent on the form, but I give an opinion. The patient had capacity, signed without undue influence, voluntarily. And so I give to the next physician, just in case it's not the same one who filled out the form, because there could be a difference of a decade or two, all he needs to rely upon one doctor's orders that another doctor fills. It's done all the time.
Thank you so much, Dr. Terman. And we are just about at our time. And I want to respect everybody's desire to get to dinner and all that sort of thing. I want to thank Thaddeus Pope very much for attending and for his input on the chat and such. He is a leading expert in medical law and clinical ethics and highly respected. And as you can tell, he knows what he's talking about as far as the chat responses he shared with us. So that was a bonus on top of Dr. Steinberg and Dr. Terman, who we are sincerely grateful to for their expertise and thoughtful guidance through this complex subject matter and very personal subject matter. So thank you for the clarity and the compassion and depth that you brought to the subject in our discussion today. And thank you to everyone who attended. Thank you for your patience through our little glitches here and there, the joys of technology.
Especially mine.
It's okay. You know,
Susan, will you preserve the chat for us, Susan?
Yes, the chat will be preserved.
Perfect. Okay. Great.
And so you all will receive the recording, and I'll just send the chat if I can just figure out how to do that. The slide decks and contact info for both of our doctors, and Dr. Terman's follow-up survey. He felt that your feedback was very valuable from those who filled out the survey. So if you will be generous enough to participate again on the follow-up survey, that'd be great.
One point on that is that if you haven't taken the before survey, well, it's too late, but you still can take the after survey. And it really is interesting because guess what? Memory loss was at the bottom of preferences, and inability to recognize patients, family, and friends was in the middle. I had some surprising results. I didn't want to talk about it too much because I didn't have the time, and I didn't want to bias you. So I'm going to send out a slightly revised version of the survey, and this can be a part of an application to an institutional review board where we could do further research on this important topic. Thank you for your willingness to do that in advance.
Great. And to everyone who's heading off, we just hope you'll join us for future webinars. Please, if you have ideas of topics that you want to hear about, people you'd like to hear from or whatever, reach out to us through our website or me directly, and we'll be happy to accommodate. So much gratitude to all of you. And I wish you a good evening and a nourishing dinner. And we will hopefully see you in another few months at the next webinar.
Thank you, Sue. Thanks. Bye, everyone.
Thank you.
Bye-bye now.
You.